Samreen, tell us when to start the meeting, yeah?
Sir, you can start now.
Good evening, all. It's a pleasure and honor to invite you all for the masterclass in bladder cancer. All of you know that the month of May is usually remembered as Bladder Cancer Month in order to highlight the importance of this malignancy, even though less in numbers, but very profound impact on patient's life. Today in the masterclass, we are going to discuss about a very particular aspect of the bladder cancer management, which is the management of the variant histology. Of late, we are getting more and more reports on that, as well as the scientific publication in this is increasing as well. So I'm going to present to you this webinar on the variant histology of bladder cancer, and it is convened by Dr. Srivatsa from Bangalore. Before that, I'm going to invite our president, Dr. J.N.K. sir, to tell a few words about the meeting.
Well, good evening to you, and excellent program. As I said, 2 weeks ago, we talked about, on 11th of May, we back to basics, which was also a very hit. And I think in continuation to that, what you have done is when exactly in terms of what SOGO should be doing. You got to look into the subset problems like, variants histology in bladder cancer. And I think that's a very good topic. And I'm all interested in looking forward to hear from all the guys that these are the nuances of treating the bladder cancer, especially with the variant histology. With these remarks, I think I would request Dr. Srivatsa to please carry on. Thank you very much. And welcome.
Thank you, sir.
Good evening to all. Thank you very much, sir, for the introduction. And thanks to the office bearers of SOGO for giving me this wonderful opportunity of conducting a masterclass on bladder cancer, a topic dear to me. And I would also like to thank Dr. Raghavan in particular, because when we discussed, variant histology stood out as the most intriguing topic that should be discussed in bladder cancer. And so we have tried to kind of compile 4 relevant talks, one from the pathologist, one from the molecular biologist, one from the urologist, and one from the medical oncologist, followed by a panel discussion involving 4 experts on management of various aspects of variant histology. So without wasting much time, I would like to invite the first speaker of the day, Dr. Divya. Dr. Divya is a consultant oncopathologist at Sri Shankara Cancer Hospital, Bangalore, and she will be presenting the pathological perspectives of variant histology in bladder cancer. Over to you, Dr. Divya.
Good evening, one and all. Thank you, Dr. Srivatsa, for the kind introduction. It gives me immense pleasure to be part of this multidisciplinary meet. And without delay, I've been asked to go ahead with the introduction to the pathological variants in bladder cancer. I hope I'm audible.
Yes, madam, you're audible and the screen is seen.
Yes. So coming to the introduction, bladder cancer, as everybody knows, is the 10th most common cancer worldwide, with an estimated incidence of 5.7 lakh new cases in 2020, representing approximately 3% of all cancers. It is the 13th most common cause of cancer-related mortality, and urothelial carcinoma accounts for more than 90% of all bladder cancers. There's a lot of pressure now and a lot of efforts which are being put in to identify clinico-pathological factors which significantly affect the outcome of these urothelial carcinoma cases. So this led to the identification of these so-called variant histology. So a variant histology describes any distinctively different histomorphological phenotype of a conventional urothelial carcinoma that is believed to be derived from urothelial carcinoma and is typically admixed with conventional urothelial carcinoma in the same tumor. So this differentiation into variant histology occurs in approximately 25% of cases as per literature. In 2022, the 5th edition of the WHO classification of urinary and male genital tumors was launched. And in this, this book avoids the term variant for histology. The term subtype is used more often. The term variant is used to denote genomic alterations. So in this topic, I would like to avoid the term variant and use the term subtype instead. So recognition of the histological subtype is important because they may be associated with different clinical outcomes, may require a different therapeutic approach, and awareness is very important in avoiding diagnostic misinterpretations. There are two general rules for pathologists. One is the histological subtype should be documented and even quantified because metastatic tumors will continue to exhibit the same distinct histological pattern. And there is also always a possibility that this tumor in the bladder represents a metastasis or a secondary involvement from an adjacent malignancy. This should always be considered and ruled out. So coming to a simplified version of the complex classification of the urothelial carcinoma. So we have urothelial carcinoma and the non-urothelial carcinomas, which are squamous and adeno, and other tumors like sarcoma, lymphoma, melanoma, and other tumors. Of urothelial carcinoma, which constitutes more than 90% of cases, we have tumors which exhibit divergent differentiation as well as the subtypes. I'll be discussing each one in detail. The neuroendocrine neoplasms are a separate category, but they're discussed here because they have distinct prognostic and therapeutic implications. The molecular classification will be discussed by Dr. Aruna later, hence I'll not go into details of these, but I would like to emphasize that each histological variant, the so-called variant, will correlate with a molecular subtype, and the neuroendocrine like basal squamous and the luminal unstable types are associated with worse overall survival. This is a gross photograph showing a conventional urothelial carcinoma. We see the cut section is showing papillary and polypoid projections involving the entire of the bladder. This is a low-grade papillary urothelial carcinoma with minimal cytological and architectural atypia, whereas this is a high-grade papillary urothelial carcinoma. Now, this is a flat lesion. It is a urothelial carcinoma in situ, exhibiting dysplasia of the entire thickness of the bladder wall. On the right, we see an invasive urothelial carcinoma of the conventional type. There's carcinoma in situ superficially, and this invasive component, which is also seen infiltrating the muscularis propria invasion. The invasion of the muscularis propria is the single most important factor which determines prognosis. Now, coming to the subtypes which show divergent differentiation of these, squamous differentiation is very common, as we see in this picture here. So there's a conventional urothelial carcinoma component denoted by the star. And here we see the squamous differentiation, where we can identify either squamous pearls or individual cell keratinization here, or they may be intercellular bridges. And glandular differentiation occurs in approximately 18% of cases. We can have trophoblastic differentiation and Mullerian differentiation, which are quite rare. Squamous and glandular differentiation are not significantly associated with worse overall survival as per literature. Coming to the histological subtypes of urothelial carcinoma, we have this micropapillary carcinoma, which is defined by the presence of small clusters, as we see in this photomicrograph. And these are seen within lacunae. These may resemble a lymphovascular invasion. Lymphovascular invasion, and carcinoma in situ or an invasive conventional urothelial carcinoma is also found associated with this tumor. Overexpression of HER2 is frequent, and this could offer a target for therapy. A recent study on gene expression signatures show that micropapillary tumors are mostly of the luminal subtype. Dr. Aruna will be discussing later, but this micropapillary variant is heterogeneous at the genetic level. And of this, there is a subtype which has this P53 subtype, and this is associated with chemotherapy resistance and is the most aggressive of all urothelial carcinomas. We have some variants of urothelial carcinoma which have a deceivingly bland histology. One of them is this nested urothelial carcinoma, which shows small round to ovoid nests of urothelial cells as seen here, which will mimic the von Brunn nests. Von Brunn nests are the benign proliferation of urothelium, which are seen as nests in the lamina propria. But what helps in making this diagnosis of a nested urothelial carcinoma is the presence of the confluence of these multiple nests, irregular infiltrative base of the lesion, which involves the muscularis propria, and increasing cytological atypia in the deeper aspect of the tumor. In a small biopsy sample or a TURBT sample, identification of third promoter mutations may help in diagnosis. But there's no evidence to say that this behaves clinically differently from a conventional urothelial carcinoma. There's also a large nested subtype where instead of small nests, we have these large sheets of cells, which may mimic a non-invasive urothelial carcinoma with an inverted pattern. Again, infiltration of the muscularis propria as seen here will help in diagnosis. In spite of the bland histological features, this presents with a poor prognosis and distant metastasis. Tubular and microcystic urothelial carcinoma is another bland variant where we see these cells lining cystic spaces or tubules. And again, these may mimic cystitis cystica, which is again a benign lesion, but infiltration of the musculatus propria and irregular infiltration will help in making this diagnosis. One aggressive subtype is this plasmacytoid urothelial carcinoma, which is characterized by singly infiltrating cells, which may or may not have cytoplasmic lumina. The difficulty here is they may resemble plasma cells, and hence the whole lesion may look like a plasmacytoma or a lymphoma. They may also resemble signature cell carcinoma cells, but they lack extracellular mucin. So the discursive tumor cells may spread extensively along tissue planes. There's often involvement of the external surface, and positive surgical margins are very common, and it is difficult to identify this in a frozen section evaluation. Another diagnostic pitfall here is the plasma cell marker CD138 is often positive in these, but the co-expression of urothelial markers like P63 and GATA3 will help in making this diagnosis. Now, this subtype is characterized by mutations of CDH1, which is similar to lobular carcinoma of breast and signature gastric carcinoma, and this leads to loss of E-cadherin, which results in enhanced tumor cell migration and tendency of these tumors to recur locally and peritoneal metastasis. Now, this was a case with which was sarcomatoid urothelial carcinoma. So there is an appearance which is intermediate between a true epithelial carcinoma and a sarcoma. However, a conventional urothelial squamous or glandular component or even carcinoma in situ is found associated, which helps in making this diagnosis. Now, spindle cells may be bland spindle cells, or they may resemble an undifferentiated pleomorphic sarcoma. Heterologous components may be seen. Markers of urothelial differentiation like P63, GATA3, and high molecular weight cytokeratin will help in making these diagnoses. And we must differentiate benign myofibroblastic proliferation from the sarcomatoid urothelial carcinoma. The survival of the patients with sarcomatoid urothelial carcinoma is particularly poor. We have some rare subtypes like the lipid-rich urothelial carcinoma, which has intracytoplasmic vacuoles. We have this lymphoepithelioma-like carcinoma, where there are sensation sheets of tumor cells, which are admixed with a dense lymphocytic and plasma cell infiltrate, which resembles the counterpart in nasopharynx or oropharynx. But the difference here is there's no association PBV or HPV, which is seen there. The lymphoepithelial carcinoma may be pure or may be associated with urothelial conventional urothelial carcinoma. IHC is required to make this diagnosis, and a recent study has found that these tumors are enriched with a basal or squamous molecular subtype and shows PD-L1 expression, and this leads to chemosensitivity of these tumors. We have this clear cell or glycogen-rich urothelial carcinoma, which mimics a clear cell RCC because of the clear nature of the cytoplasm, and this has to be and IEC is required to make this diagnosis. It should also be differentiated from clear cell adenocarcinoma of the urinary tract, which is similar to its counterpart in the female genital tract, and this has an aggressive behavior. We have this rare subtype, which is the giant cell urothelial carcinoma, which shows pleomorphic giant cells, and positivity for urothelial markers will be identified, though loss of markers are known to occur in this. Behavior of this rare subtype is highly aggressive. We have this last variant, which is a poorly differentiated urothelial carcinoma. One subtype of this is an undifferentiated carcinoma with osteoclast-like giant cells, and which shows these mononucleus urothelial cells and these osteoclast type of giant cells, and these have aggressive behavior. IHC is required to make this diagnosis. Now, a separate entity is the mixed neuroendocrine neoplasms of the bladder, where there is an admixture of neuroendocrine carcinoma component and a non-neuroendocrine component like urothelial carcinoma, SCC, or an adenocarcinoma. And neuroendocrine tumors of the bladder are admixed with non-neuroendocrine components in as many as 50% of cases. Now, this photomicrograph shows a conventional urothelial carcinoma in situ, which is confined to the urothelium, and the lamina propria shows sheets of these small cells with nuclear molding and karyorrhexis and this neuroendocrine appearance. So this is a small cell carcinoma of the urinary bladder. Given the limited survival results with surgery alone, these patients are believed to respond to multimodality therapy. Now, this is just a review of the last 100 cases of radical cystectomies at Sri Shankara Cancer Hospital. And high-grade urothelial conventional carcinoma constituted 57% of the cases. Of the so-called variant cases, squamous differentiation was seen in 22% cases, micropapillary in 4%, and the rest were rare. Coming to diagnostic molecular pathology, TERT promoter mutations are the most common genetic alterations used in urothelial carcinoma, and these are used to distinguish bland malignant processes, such as the nested subtype from benign proliferative conditions. It also helps in establishing a urothelial origin of these tumors, and this can also be tested on urine samples and helps in making this diagnosis in a non-invasive way. In advanced urothelial carcinoma, evaluation of FGFR3 alterations can help in determining the eligibility of these tumors with anti-FGFR agents. PD-L1 expression in tumor and immune cells has been tested using SP263 and SP142 as well. And these can be used as predictors of response to immune checkpoint inhibitor therapy. Prognostic implications of these histological subtypes are globally, these subtypes of urothelial carcinomas are considered an adverse risk feature. Since these tumors often present with higher stage, it is essential to assess prognosis after correcting for stage. Squamous and glandular differentiation appear to have little impact on prognosis, but variants such as the micropapillary, sarcomatoid, plasmacytoid, and small cell carcinoma are associated with higher disease stage and higher risk of recurrence in progression and decreased survival. The relative impact of these subtypes on clinical outcomes needs to be considered separately in the non-MIBC, in the muscle invasive, and in the metastatic settings. So to conclude, a familiarity with the histological subtypes is crucial for both pathologists and clinicians for appropriate diagnosis and management. Each individual subtype is relatively rare. Inter-observer variability in diagnosis of subtypes remains high. So guidelines on management of subtypes are based on small subgroup analysis, expert consensus, or even applications of treatment used in other organs. Therefore, an awareness of the current evidence and further research are crucial to optimize the treatment of these subtypes of urothelial carcinoma. Thank you.
Thank you, Dr. Divya, for this exhaustive pathological description of how the subtypes of bladder cancer, not variant histology, looks. It's time for one quick question. Anybody?
Yes, sir.
Yeah. So I
would like to take any questions. Yeah.
Dr. Divya, I have one question.
Yes, sir.
How easy to identify
Yes, sir.
variants? Because many a times, if pathology is not good, they miss. So how easy? What are the tips for the pathologist?
So some variants are easily picked up. For example, the divergent differentiation like squamous, glandular are easily picked up. And what becomes important is identifying the associated conventional component as well. Whereas there are subtypes where the diagnosis is difficult. For example, the plasmacytoid variant. In fact, we had a case which was quite challenging. They look very much like inflammatory cells, and even lymphoepithelioma like carcinomas and other subtypes, they require IHC for diagnosis. And we would like to use a panel of markers, which would include the conventional urothelial carcinoma markers like P63 and high molecular weight cytokeratin, and other markers which would help in coming to this diagnosis.
Thank you.
Judicious use of IHC is required, sir, to identify these variants.
Just one more point here, Srivats and Dr. Divya. There is a question in the Q&A section. Dr. Bindu has asked a question. How about metastatic spread to the bladder, metastatic tumors to the bladder? Any comments on that? Just a short comment will suffice.
Okay, so metastatic tumors are known to occur in bladder. In fact, more than distant metastasis, we have come across cases of colorectal carcinomas and carcinomas of the cervix infiltrating the bladder. So many times it becomes challenging because both the luminal aspect and the external surface are involved, and IHC many times doesn't help in diagnosis. So we'll have to first go back to the history and check what was the primary tumor, and whether and compare the previous histology with the current histology, and even do IHC on both sets of cases, like the previous case and the new case, and come to a diagnosis. Carcinomas of breast may metastasize to bladder, as I discussed, and they may resemble the plasmacytoid variant, but in that case, IHC will help in diagnosis. Sometimes there may be overlapping markers like P63, which is expressed in breast as well, but other markers like mammoglobin will help in diagnosis. So depending on the case and the history of previous illness, we can come to a diagnosis.
Thank you.
Jagdish sir, Kulkarni sir wants to ask a query.
One question is, I saw that trophoblastic type of tumors, and years ago we had a tumor. How do you now recognize that trophoblastic disease?
The trophoblastic disease, the patient may present with slightly elevated beta HCG levels, and on morphology, in fact, it is not very difficult to identify the syncytial trophoblast type of giant cells. They are quite unique, and one can even do IHC for beta HCG to make this diagnosis. It is relatively rare. In fact, we have not come across such a case.
Dr. Santosh, very quickly, last
comment. Thank you, Divya, for the very nice presentation.
Thank you,
Am
sir.
I audible? Yeah, I just wanted to add that when we talk of metastasis, before metastasis, I think very important to remember that many prostate cancers can resemble bladder cancers. So high grade.
Yes.
So the first thing, and the treatment is so different that we always need to keep that in mind, that prostate cancer can present as bladder mass, the lateral wall growing through it. And that's very, 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 very important not to miss prostate cancer first.
Yes.
Thank you so much. One request to all the panelists: kindly have a look at the Q&A sections, and there are a lot of viewers are asking questions. It may be very difficult to answer every question in the open forum, so please do not hesitate to type your answer in the Q&A section for the viewers as well. With that note, can we move to the next topic, please? Thanks.
Thank you very much, Dr. Divya. This was an excellent presentation. May I now request Dr. Aruna, Principal Scientist at Sri Shankara Cancer Hospital, a molecular biologist, to discuss the molecular classification in variant histology of bladder cancer, its impact on risk stratification and therapeutic strategies. Over to you, Dr. Aruna. Dr. Divya, can you stop sharing your screen so that Dr. Aruna can... Dr. Aruna? Can you also please unmute yourself? Yeah.
Am I audible?
Yeah, you are audible, madam. Can you put it on full screen and then we can start?
Am
yes,
I?
Yes, ma'am.
Yes. Okay for everybody. Okay. Very good evening, and I'm glad I'm following after Dr. Divya. I think she made my job very easy, and with all those beautiful slides that we could see the differential between each variant. This is what I'm going to talk about is a little bit different. We take all of it, grind it up, and look at the DNA or RNA and arrive at certain conclusions, which is actually rapidly picking up to be a very important aspect while diagnosing as well as managing bladder cancer. And quickly, let's move to that. For this audience, I don't think I need to stress about the incidence and occurrence of bladder cancer. We just know that it's the most common malignant tumor involving the urinary tract. Conventionally, we know that it can be divided into non-muscle invasive and muscle invasive based on the invasion of the muscularis propria. So why is there a need for molecular subclasses? I mean, we just heard Dr. Divya. By looking at the tumor under the microscope, it is so beautifully differential between each of these subtypes. Then why is it that we need a molecular subclass? Variability in terminology has actually created a challenge in a molecular classification of early stage bladder cancer. And treating clinicians always emphasize the dichotomous division of bladder cancers into NMIBC and MIBC, and often lump all the NMIBCs together when we are planning molecular studies. In contrast, pathologists tend to see a stark difference between the different tumors and classify them accordingly. So traditional classifications for bladder cancer are mainly based on pathological features and the tumor stage. However, even with similar path staging, grading, recurrence, and progression of bladder cancer, we still see a marked heterogeneity because there is a large unresolved class of that intermediate class that we don't know how to resolve. And that directly affects management of these patients. So with the rapid development of sequencing, mass spectrometry, and other techniques based on the current omics technology, it has transformed our understanding of all human cancers and also bladder cancers. So this is a quick cartoon to represent, before I go into the actual molecular subclasses, to show that discerning between that intermediate class and actually high and low risk classes is actually possible now with the molecular classes. And it's actually this particular cancer, it's a very biologically as well as clinically a very heterogeneous disease. And traditional classification systems based on grade, stage, and clinical prognosis actually fail to fully explain the tumors with similar pathology, but they do exhibit diverse biological behavior. That is where molecular subtype profiling was first attempted in bladder cancer in as recently as 2010 only. And several different molecular classification systems have actually emerged since then. And these subtypes, not only do they have distinct morphological and clinical characteristics with different therapeutic and prognostic implications, particularly in the era of targeted therapies and immunotherapy. Therefore, the necessity to molecularly classify bladder cancers is important. Now, this is how what we saw with Dr. Divya's presentation of the different types of histologies. This is how the molecular, this term that we use called intrinsic molecular subtype, it was first used in breast cancer, and it refers to subtypes which reflect intrinsic properties of different cells in the tumor. So this is how it emerges, and the luminal and basal intrinsic subtypes, they reflect the property of tumor cells to show urothelial or basal stem-like differentiation signatures. However, RNA studies or the transcriptomic studies identified the entire genetic signature of a tumor, which in the case of bladder malignancies, it included a variable component of stromal as well as immune signatures. So there are non-luminal muscle invasive bladder cancers. I have to remind you that a lot of work has in the molecular subclassification has actually been achieved in muscle invasive bladder cancers, much more than non-muscle invasive. And we also have the neuronal or the small cell neuroendocrine MIBCs. The basal subtype has actually been renamed most recently as the basal squamous in the later classification systems. Now, the basal subtype, as we see here, it has, these are mutations as well as what pathways are actually active in these subtypes of breast cancers. And we see largely that there are FGFR mutations, PPAR gamma being activated, and TP53 losing its wild type. There are a group of these APOBEC mutations that form still the luminal. And within luminal, we have the papillary. If you remember the slide that Dr. Divya showed of how the papillaries look. And then the luminal non-specified, which are actually the non-papillary and everything else that comes into the non-specified, and unstable, which largely has genomic instability, and it has a lot of DNA damage repair mutations and DNA damage repair pathway being inactivated, and differential expression of different cell cycle associated proteins, and therefore a lot of oncogenic mutations. And then we have the stroma rich group, And this is very interesting that just like how we had the intrinsic molecular classification that first came about in breast cancer, and we had the 50 gene signature called PAM50, which first separated breast cancers into 5 different intrinsic subtypes. Similarly, even in bladder cancers, we have the Claudin-Low subgroup, which actually has a lot of stem-like features. There are a lot of epithelial mesenchymal transition signatures and tumor initiation cell markers. So there is a significant enrichment in genes related also to inflammatory cell infiltration, and immune checkpoint was also seen in the basal subgroup, and more specifically among the Claudin-Low tumors. So these are several different groups which actually classified the bladder cancers, and into these genomic instability is there, luminal, luminal basal, and luminal cluster 1, cluster 2, and most recently in 2017, TCGA reclassified everything as luminal papillary and luminal, and 2 different types of these, luminal non-specific and luminal papillary. So this is the most recent classification. Like I mentioned earlier, much of the work on molecular subtyping of bladder cancer has been done in muscle invasive bladder cancers in consideration, and an increasing number of classification systems which have emerged with these several other groups working on them. Although the subtypes within these systems are actually largely similar, they differ in clinical and biologically very different and meaningful ways. Now, the basal, for example, going back to my earlier slide, there are a lot of keratin expressions, and then, sorry about that. Yeah, there are a lot of keratins which are being expressed, and sorry, my screen is frozen. Yeah, keratins, and there are also these FGFR3 and GATA3 mutations, FOXA7 mutations that help in subclassification. And the most recent 2017, like I said, has actually these luminal tumors, which are divided into luminal papillary and luminal non-specific. And these different clusters, cluster 1, cluster 2, cluster 3, they express the squamoid phenotype and its associated keratin expression. So we currently now, to sum it up, we have luminal into 3 subtypes: luminal papillary, luminal, and luminal infiltrated. They also included a neural subtype in addition to the earlier described basal subtype. So these are the markers again that are associated with different and their different methods of detection are also depicted here. We have both RNA based as well as tissue based markers. It could be both by qPCR as well as Dr. Divya alluded to, IHC, and both coming together will help in the differential classification. So yeah, this was actually a very interesting study which used a lot of traditional classifications of bladder cancers and their molecular subtypes, and they can be divided into luminal and non-luminal subtypes based on the degree of differentiation. And you can see here that these overlapping with molecular, histological, and clinical subtypes, there are so many different genes and so many different activated pathways in the same group. Now, this was a recent Nature paper. I want to stress on this, that this paper utilized multi-omics analysis, and they have classified the non-muscle invasive bladder cancers only into classes 2A and 2B. And they demonstrated that genomic and transcriptomic subtypes showed independent prognostic value when compared to clinical risk factors. So in this study, they compared gene expression-wise substratification with the prognostic score and the recurrence score that are clinically utilized. And they showed that over and above what is pathological and clinical classification, this gene expression based classification into 2A and 2B actually brought about a much superior independent prognostic value beyond the established clinico-pathological parameters. So here we are. There are so many of these markers which play a very important role in classification. So by looking at multi-analyte analysis of DNA, RNA, and protein, we have the ability now to predict the response early in the course of the treatment. It is certainly important to distinguish patients who will likely to benefit from what kinds of treatment. So then the question arises, what do we test for? How much of validation exists? And here is a depiction of all of these markers which have proved to be extremely useful in arriving at a better intrinsic classification that certainly only adds to clinico-pathological classification. So a brief mention about the tests that already exist for this purpose. There is a company called Oncologists, which recently made a breakthrough with FDA. And it is a predictive assay for response to BCG treatment. Eurovision is another commercially available fish assay. And then there are several neutrophil to lymphocyte ratio-based tests that are available. Now, not only do clinical outcomes differ, but there are also outcomes in differences in therapeutic responses. The gold standard for management of all MIBCs, I have to stress, is confined to the pelvis. That includes radical cystectomy, of course. And there are many other features that we have to consider when we bring together these predictive markers. There are many alterations in the DNA repair pathways that can be used as predictors for response. We still have to work a lot on epigenetic alterations like the non-coding RNAs, the microRNAs, and we have not yet touched much upon circulating tumor cells and other protective vesicles that transport microRNA and non-coding RNAs to a distant metastatic site. Very little is still known about bladder cancer and microbiome, which we have to work on. And the landscape is changing. The treatment landscape is quickly changing with introduction of several other immunotherapy strategies. And with improved sequencing techniques, the omics work has become easier now to do the substratification and prediction of where a single sample can fall into which class. And therefore, we can predict better. And biomarker-based.
When we conclude?
Yes, this is my last slide. And I would like to say that in bladder cancer, we don't have yet too many biomarkers that have made their way into the clinic. And I think all of us have to work towards that. However, it is hopeful that soon we will get there. And even in our institute, we are working on this, and hopefully we will have something very soon. Sorry for stepping over my time. I didn't realize. If there is time, I can take questions. Otherwise, I can take it offline as well. Thank you.
Thank you very much, Dr. Aruna, for the comprehensive overview of the molecular landscape of the bladder cancer. Obviously, there are more things to be done, and it's in early stages. Any questions can be please asked on the Q&A forum, and I would request Dr. Aruna to answer them.
Sure, I'll do that. Thank you.
Yeah. May I now invite Dr. Ravichandran, consultant uro-oncologist at Apollo Hospitals, Bangalore, to present his talk on overview of management of bladder cancers with variant histology. Over to you, Dr. Ravichandran.
Good evening, sir. Am I audible? Is my slides visible, sir?
Yeah, both audible and visible, Dr. Ravi. We can proceed.
Thank you. Thank you for this opportunity. My previous two speakers have extensively discussed on pathology and molecular aspects of variant histology. I'll be talking on overview of management of bladder cancers with variant histology. Bladder subtype histology has been seen in up to 10 to 25% of overall cases. However, the incidence has a long range depending on the era of the publication and the center from where the study has been done. And there has been nearly 50% discordance between the TURBT and the cystectomy pathology reporting. And up to 44% of cases of subtypes are not recognized by the community pathologist. As Raghunath sir was rightly asking, how easy or how difficult is it to pick up these variant histology by a community pathologist is to be seen. And in order of decreasing frequency of misdiagnosis, the most commonly missed subtype is lymphoepithelial, followed by plasmacytoid, and then nested variant, micropapillary, and small cell histology. Coming to WHO classification of urothelial cancer, which Divya ma'am had extensively discussed. In my topic, I'll be focusing mainly on the two pure variants, that is squamous cell carcinoma and adenocarcinoma, followed by multiple subtypes and the neuroendocrine tumors and sarcomas. Well, coming to first pure subtype, that is squamous cell carcinoma, 2 to 5% of all bladder cancer diagnosed have squamous cell carcinoma, and up to 85% of these cases are muscle invasive at the diagnosis. I have two papers to show you. This is from Mansoura Institute in Egypt, where they have evaluated squamous cell carcinoma. The overall survival between squamous and rest of the urothelial, there is MSK even carcinoma, and it harbored worse overall survival and disease-specific survival. Probably in stage 1 and stage 2, the difference in overall survival is not much, but certainly in stage 3 and stage 4, the squamous cell carcinoma fared worse. In metastatic setting, the overall survival, median overall survival is 5 months compared to 10 months in rest of the variants. And in squamous cell carcinoma, radical cystectomy is the best treatment option. There is no role for neoadjuvant chemotherapy or for radiation therapy. Next, coming to adenocarcinoma, 2% of all bladder cancers. And majorly, there are two types, urachal and enteric type, which have similar histology and genetic alteration. They typically carry TP53 mutation, which is seen in 80% of cases, and EGFR and FGFR amplification in up to 35% of cases. These urachal adenocarcinomas are frequently metastatic in nature, high risk of local recurrence, and they carry poor prognosis. Surgery is en bloc resection of bladder dome and urachal remnant, and they're responsive to 5-fluorouracil, leucovorin, and oxaliplatin. There was a SEER population-based study wherein they evaluated 2,300 cases of primary adenocarcinomas of bladder, and 5 years
So, Dr. Ravi, your voice is not audible. I think Dr. Ravi had an issue with the internet. Ravi?
Hello. Yes, am I audible, sir?
Yeah, right. Yeah, right now, yes, you are. Please load your presentation again.
Yes. Am I good to go?
Yeah, yes, you are.
Okay, sir. So as I was discussing, the urachal or dome location tumors had a survival advantage over non-urachal locations. Signet cell carcinoma and unclassified adenocarcinomas conferred worse prognosis. Coming to micropapillary urothelial carcinomas, this has carried a lot of interest of late. Initial papers had an incidence of hardly 0.6 to 1%, but of late, the incidence of up to 6% has been seen, probably due to increased awareness of this agent, aggressive this with poor prognosis. In 2007, there was a paper published by Dr. Ashish Kamat's team from MD Anderson, where they studied 100 curative patients of micropapillary bladder cancer, wherein nearly 44 of these 100 patients, they attempted bladder sparing therapy with intravesical BCG. However, 67% of these patients developed disease progression, including 22% who developed metastatic disease. And other 55 patients underwent radical cystectomy, of which 23 received neoadjuvant and rest of them underwent upfront cystectomy. Overall, the conclusion of this paper was that intravesical therapy appeared to be ineffective in micropapillary bladder cancer. And the same team updated their data in 2015, wherein they looked at clinical outcomes of clinical T1 micropapillary bladder cancer. And as we can see here, the 5-year disease-specific survival between upfront cystectomy and primary BCG is significant, almost 100% versus 60%. However, there was another paper by MSKCC group, wherein they evaluated 21 patients with T1 micropapillary urothelial cancer, which were treated with BCG after restaging TURBT. In their study population, the 5-year cancer-specific survival was similar between patients treated with BCG versus upfront radical cystectomy. The possible explanation for this difference in behavior is that in MSKCC group, they considered BCG after a restaging TURBT, contrary to the MD Anderson group. Well, next, coming to role of neoadjuvant chemotherapy in micropapillary, there were 3 big data, one from National Cancer Database, MD Anderson, and MSKCC group. All the 3 studies showed significant downstaging. However, there was no survival benefit. Coming to plasmacytoid urothelial subtype, they are an aggressive subtype, and majority of them are locally advanced at the time of diagnosis, probably infiltrating rectum, pelvic wall, or prostate. And as Divya ma'am has discussed, there is a loss of echedrin protein, which are seen in up to 70% of cases, contrary to 11% in conventional urothelial carcinoma. And truncating mutations in CDH is seen in 87% of cases versus 0. These plasmacytoid are chemosensitive, but then they carry poor prognosis. There was this one paper wherein they evaluated close to 98 of these patients. As we can see here, the rate of positive soft tissue surgical margin was over 5 times greater than compared to pure urothelial cancer because of their inclination and tendency for locally advanced disease status. And the median OS for pure urothelial was 8 years, whereas for plasmacytoid was just 3.8 years. Next, coming to nested subtypes, they have bland appearing cells which mimic a low-grade cancer, but which are invasive. Whenever we come across pathology reports stating that it is invasive, but then it is low-grade, we usually start questioning the pathology report. However, we need to keep in mind that nested variant can sometimes present that way, where they mimic benign urothelial proliferations like von Brunn nest or inverted urothelial papillomas. There was one matched cohort analysis of 52 patients, wherein this nested variant was associated with high rate of adverse pathological features in up to 69% who had a T3 and T4 disease, and 19% of patients had nodal invasion. And when these patients with nested variant were matched to a cohort with pure urothelial carcinomas, no significant difference was noted in 10-year local recurrence-free survival or 10-year cancer-specific survival. Next, coming to sarcoma type, 0.6% of bladder cancers. The risk factors are radiation therapy, intravesical cyclophosphamide. These cases present with high stage and grade with metastasis, and they're usually very aggressive. There has been no large series to guide therapy and controversy regarding response to chemotherapy and radiation. Coming to neuroendocrine subtypes, either they can be small or large cell mixed with pure urothelial cancers, usually diagnosed with IHC. Since they have high chances of occult metastasis, no much role for intravesical therapy. Standard of care is to give neoadjuvant chemotherapy with cisplatin or cisplatin etoposide, followed by cystectomy or radiation. And non-muscle invasive neuroendocrine tumors, they respond well for a BCG along with some systemic therapy. Next, coming to urothelial carcinoma with divergent differentiation. To begin with, the squamous differentiation. This is the most reported subtype, close to 21%. In this, about 20 to 60% of them are muscle invasive. Early non-muscle invasive bladder cancer with squamous differentiation, we can try with intravesical immunotherapy followed by close surveillance. Neoadjuvant chemotherapy results in high likelihood to achieve pathological complete response and higher incidence of downstaging. Once radical cystectomy is done, patients who had neoadjuvant chemotherapy had a better overall survival and recurrence-free survival outcomes at a median follow-up of 38.2 months and almost similar survival outcomes compared to conventional urothelial carcinoma. And there are excellent rates of complete pathological response with trimodal bladder preserving therapy as well. Next, coming to urothelial carcinoma with divergent differentiation of glandular, that is adenocarcinoma kind of a differentiation. This is the second most reported histological subtype, 6 to 10%. This presence of differentiation, the extent of the glandular differentiation, even focally in association with urothelial carcinoma, portends a poor prognosis. Similar to squamous differentiation, they respond reasonably well to neoadjuvant chemotherapy, and survival outcomes after radical cystectomy almost similar as in conventional or in divergent squamous groups. Next, any T2 bladder cancer with a subtype histology, treatment is quite straightforward. Neoadjuvant chemotherapy can be given, if not for survival benefit, at least for downstaging, followed by cystectomy or radiation as and when it's applied. However, for a clinically TA or T1 urothelial cancers with aberrant histology is where the lot of dilemma is. This is the flowchart from AUA guidelines, where in urothelial carcinoma with squamous or glandular differentiation, we can try treating like a conventional urothelial carcinoma with a re-TURBT and BCG. If it's a neuroendocrine, wherein small cell with or without urothelial conventional one, we can try with systemic chemotherapy plus cystectomy or radiation. Any sarcomatoid or non-urothelial ones like sarcomas, upfront cystectomy plus or chemotherapy is better. Micropapillary, plasmacytoid, nested, and in selected divergent variations, if at all they are multifocal or if they are large tumors, and if there are deep lamina propria invasion, if there is a lymphovascular invasion or a recurrence following BCG, better to go for cystectomy. If not, can consider re-TURBT and intravesical BCG. Well, to conclude, the diagnostic and treatment dilemmas due to their rarity and aggressive nature is well known. We don't have any big level 1 evidence data for this subtype histology. Most of them are either population-based or a single large center data. And the role of neoadjuvant chemotherapy in the treatment strategy is yet to be well defined. However, there is certainly a benefit in terms of downstaging, if not for overall survival. And subtypes of urothelial cancers are a heterogeneous tumors, and responsiveness to neoadjuvant chemotherapy may be a function of molecular subtypes. As Aruna ma'am has described, probably with better understanding of molecular subtypes, we may be in a better position to deal with this rare and aggressive types of cancer. Thank you. Thank you for the opportunity.
Thank you, Dr. Ravi. It was a nice presentation. We have time for 2 questions. Anyone from the audience?
I have a question.
Yes, sir.
Ravi, is there any concern about
Yes, sir.
diversion? Can we go for a neobladder in this patient without much issue? Any data from the
there is
paper?
no absolute data. No, sir. There is no data for your question, sir. Just that our understanding is that most of these variants are aggressive with a poor prognosis. With our limited understanding, there is very limited data for this, sir, for neobladder invariant histology.
Kulkarni sir, yes sir.
I just wanted to ask you one question, that is, tumors in diverticulum. There has been no information at all. Is there any data on subtypes in tumors of diverticulum? And if so, what could be the treatment? I mean, is it the same radical cystectomy as we've been doing? But any information on tumors in diverticulum?
So there have been no comment on these subtypes in diverticulum. I didn't come across any such data in literature. However, I think as we make a decision for the conventional urothelial carcinoma, I think it should apply the same for variant histology as well, sir. But just to keep in mind that their innate nature is to be aggressive. So probably our treatment plan can also be aggressive, sir. But there is no data, sir.
The issue I'm asking is because there is no muscle in the diverticulum, and this is just a mucosal tumor. If at all it is a tumor in the muscle, mucosal tumor, but still behaves in a different way completely. So that's where I was a little concerned, because if 4 decades ago we have been doing the same thing which we were doing in 80s. So that's one area which I thought of it would be interesting. Thank you. Thank you.
Comment, sir. In this tumor, sometimes the detection of muscle invasion may be confusing. Like in nested variant, it usually involves the muscle very early, and it will be very difficult to identify this tumor also. It may look like a benign entity sometimes. So that is why it is better not to take any risk in nested variants. More than the aggressiveness, that is a confusion that can happen when it become muscle invasive. Any comment from Santosh?
Ginil, hi Ginil. Just wanted to add that the micropapillary subtype is known to have a lot of CIS associated with it. Around 50-60% of the cases of micropapillary do have very extensive CIS. So I don't know whether that would be a deterrent for you to do a neobladder. That's my query to you. Query or comment.
Yeah, I was also thinking because these pathologies doesn't have much data to say that neobladders are safe, and sometimes the assessment of tumor cells at the tip of urethra sometimes may be confusing for pathologists also in the process section. These are the 2 issues because of which probably I'll be a bit concerned about going for a neobladder in this film. But thing is, as Ravi has told, there is no large data on whether neobladders are safe in this variant. But this is confusing thing. The process section will be confusing, can be very aggressive.
So Ginil, the plasmacytoid is known to track around the ureter and urethra and all that, and is known to recur in the neobladder and known to recur in the pouch which you create from the intestinal pouch. So those are very, very subtle tumors which grow underneath the mucosa, and they can really cause problems. So I don't think plasmacytoid variant or a very florid multifocal micropapillary would be a good tumor for a neobladder.
Yeah,
I don't
also,
know about
I would like to quickly share a case that we had, something very similar. He was a young man, 39 years. So in the initial TURBT histology, the variant histology was not attributed to. Subsequently, when we did a cystectomy and a neobladder, we had extensive squamous differentiation, and this patient typically after 2 years came to us with an hourglass contracted bladder. When we tried to do a biopsy, we found out that though the mucosa was normal, submucosally the disease was there everywhere and was tracking from the ureters. So I think neobladder in variant histology might be actually dicey. Raghunath sir, yes.
Yeah. In fact, many reports says that if it is stage 1 and 2, it behaves almost like a conventional urothelial carcinoma. Even neobladders have been done in the literature without any adverse outcomes. I mean, we cannot apply this for all variants.
I think there are a few questions which can be answered in the Q&A chat box. We are a little behind schedule, so can I now invite Dr. Nitin Yashas, consultant medical oncologist at Manipal Hospitals, Bangalore, to present his talk on novel therapeutics and management of bladder cancer with variant histology. Over to you, Dr. Nitin. Dr. Nitin, we can see your slide, but you are not audible as yet.
Yeah. Am I audible now, sir?
Yeah, you are. Yes. Please.
Yeah, sure. Thank you, Dr. Srivatsa and Sogo, for giving me this opportunity. It's a great honor to be presenting in front of such esteemed clinicians, seniors, and doctors. So I'm going to be talking about systemic chemotherapy and novel therapeutics in the management of variant histology of bladder cancer. Now, as medical oncologists, for us, managing the regular urothelial bladder carcinoma is very, very straightforward now. And with the advances in immunotherapy and novel therapeutics and sequencing, we have obtained clarity. But when Dr. Srivatsa first asked me this topic, this was what I was going through. What do we give in variant histology in systemic? Are there any guidelines and data that we can fall back upon? So basically, I've tried to go through the literature, and I found 3 relatively newer things, which is what based on which my talk is going to be based on. There is a EAU ESMO consensus on the management of advanced and variant bladder cancer, which was a collaborative effort where they have tried to issue guidelines on what needs to be done from a systemic therapy aspect. Apart from BCG, I would be talking mostly about the systemic aspect as such. Very interesting paper, and a very good article, which I would request everyone to read when permissible, on variant histology in bladder cancer, diagnostic and clinical implication. And the last ASCO GU 2022 that really tried to shed some light on the management of rare variants in genitourinary cancers. Now, management of variant histology from a systemic aspect is like chasing a unicorn, because we do not have enough literature to tell us what is the optimal systemic therapy. And most of the times we see variants in association with regular urothelial carcinomas, barring a few histologies, and based on the percentage of variant histology, if it is more than 50%. Pure variants we need to keep in mind are rare tumors, and therefore any evidence that we present is purely based on retrospective studies, or it is based on anecdotal experiences or small number of case series. Now, the biggest challenge is, of course, conducting prospective trials because of the rarity and small numbers as such. So I would first start off by addressing the question, when is NACT needed or neoadjuvant chemotherapy needed in variant histology bladder cancers? Dr. Ravi almost covered few aspects of it. So we have a large data set, relatively large data set of 369 patients of variant histology who received neoadjuvant chemotherapy, and these were compared to 1,500 odd patients who underwent upfront radical cystectomy. What it clearly showed us was that neuroendocrine tumors or small cell tumors benefited most from neoadjuvant chemotherapy administration, and there was a OS or a survival benefit, hazards of almost 0.49, and also lower rates of non-organ confined disease at the time of radical cystectomy. You can see that the disease was spreading beyond the organs in 40% as compared to 76% when radical cystectomy was done upfront. For tumors with micropapillary differentiation, sarcomatoid, or adenocarcinoma, What the study showed was that NACT decreased the rates of non-organ confined disease. In other words, made surgery with R0 resection better, and also the surgery morbidities would possibly tend to be lower, but it did not provide a survival benefit or a survival impact. So when this question was posed to the EUA ESMO consensus guidelines group, what they made a statement was that muscle invasive bladder urothelial carcinoma with micropapillary or plasmacytoid variant or with squamous or glandular differentiation should be treated with NACT followed by radical cystectomy and concomitant lymphadenectomy. And out of the 36 experts who were there in the group, 65% voted that yes, this is where these are the histologies in which neoadjuvant chemotherapy should be considered. As we again emphasize, in neuroendocrine, it is pretty clear and straightforward. NACT is the way to go. But in these other histologies which I've mentioned, NACT should be considered. Though they do not have a survival or a OS benefit, it does help in reduction of the disease and lower rates of non-organ confined disease as such. So I'll just touch upon briefly on some of the individual histologies as such. Now, small cell carcinoma bladder, as medical oncologists, we believe that small cell is organ agnostic, so to speak. Today, we are speaking a lot in oncology of tissue agnostic therapy. The same thing with small cell carcinoma. We believe it should be organ agnostic, meaning to say, the treatment regimens that we use in the treatment of lung cancer are pretty much how we would treat small cell carcinoma of bladder. So most often cisplatin etoposide has been used as the chemotherapy regimen. There are some centers and some protocols which look at cisplatin etoposide alternating with ifosfamide and adriamycin being given as such. One of the larger data sets looking at what is the impact of systemic therapy in small cell cancer bladder comes from MD Anderson as such, where they looked at 125 patients with resectable disease. Now, again, they compared patients who received neoadjuvant chemotherapy versus those who underwent initial surgery. And it's very remarkable. You know, these days we have approvals coming in when sometimes the survival curves are just separated by the laser pointer. Here you can drive a car between the two curves as such. Neoadjuvant treatment was associated with improved OS, median OS almost touching 159 months. That's almost 10 years as such, versus just 1.5 years when upfront cystectomy was done. And furthermore, neoadjuvant chemotherapy resulted in pathological downstaging in almost 62% of tumors as such. So again, just to emphasize, neuroendocrine tumors or small cell carcinoma of bladder, neoadjuvant treatment, gold standard upfront with systemic therapy, and then you can think of either radiation or surgery as part of local treatment as such. Now, when we come to squamous and glandular differentiation as such, I am first talking of urothelial carcinomas with squamous or glandular differentiation, not pure squamous cell carcinomas. So we had the landmark S8710 trial, and that showed squamous or glandular differentiation was again associated with a worse prognosis as compared to conventional UC when radical cystectomy alone was done. But patients who received cisplatin-based chemotherapy before cystectomy, they went on to do much better. Now, like Dr. Aruna mentioned, we have the molecular classification of MIBC, and we see that basal-like tumors have a poor outcome with neoadjuvant chemotherapy. But in fact, they go on to perform very well, like the favorable subtypes when treated with chemotherapy. And again, that really shows how systemic therapy can change the outcomes of the molecular classification. And most of the squamous differentiations do fall in the basal subtypes as such. So when we talk of the glandular differentiation, and this is a paper which is still in publication, this was presented briefly at the ASCO GU 22. The most common alterations that we see are KRAS, PIK3CA, and TP53. Now, again, KRAS is a mutation which we sort of commonly see in colon cancers or colon adenocarcinomas as such, particularly in this subgroup. Again, urachal adenocarcinomas tended to express more of KRAS mutations as such, apart from the PIK3CA and the TP53, which we are seeing. So the optimal therapy, again, we do not have much information as such. We would believe that urachal adenocarcinoma or glandular differentiation, again, going by the molecular and the mutation profile, would be treated along the lines similar to colon, where we would use FOLFOX chemotherapy. And again, based on the clinical situation, we would definitely consider using a biologic such as bevacizumab or EGFR inhibition based on the KRAS mutation status. Again, the US centers have also looked at trying to modify the FOLFOX regimen. In bladder, you always believe that you want some possibly cisplatin over oxaliplatin as such. So they have come up with a regimen of 5-FU cisplatin and gemcitabine, which has shown response in about 30% of patients in the advanced or the metastatic setting. Micropapillary urothelial cancer is somewhat very confusing when it comes to guidelines and what is being followed across institutes. We know it presents at a higher stage of diagnosis usually, but when compared to UC, the recent data is saying that there are similar outcomes stage to stage. Now, what is exciting is that HER2 overexpression or amplification is usually found, but they are not necessarily linked. So just a brief basic recap: HER2 overexpression is something which we do by IHC. Amplification is something which we would look via FISH or by the NGS testing for the genomic amplification as such. Very briefly, like I said, the EAU and the ESMO have published a consensus guideline that even the micropapillary variant should possibly get neoadjuvant chemotherapy, but data in literature is conflicting. Again, from the National Cancer Database, we see that the risk of extravesical extension was reduced, but there was no overall survival benefit. In another second series of small 40 patients, there was almost 50% who were downstage to T0, but again, no survival benefit. Another study showed that there was a survival benefit, but only in the absence of hydronephrosis as such. What we know from genetic data and molecular profiling is that HER2 is expressed in almost 75% of micropapillary urothelial carcinoma, but amplification, which is the genomic overexpression, is seen in only 30% of patients. Now, while we may extrapolate like we do in colon cancer and use a combination of FOLFOX or 5-FU based therapy with trastuzumab, or in stomach cancer, which we are using, what is exciting is in oncology, we have a new drug known as TDXD or trastuzumab deruxtecan, which is an antibody drug conjugate. And already in urology, we know enfortumab vedotin is an antibody drug conjugate, which works well in a subgroup of patients. So possibly going into the future, a trial using TDXD, which is just not an antibody, but antibody drug conjugate, would possibly improve outcomes in HER2 positive micropapillary urothelial carcinoma as such. Now, plasmacytoid urothelial carcinoma, as already said, we see E-cadherin loss. It is an aggressive tumor, but more so locally aggressive as such. And even with preoperative therapy, upstaging at surgery is common. And sometimes we even do end up seeing positive surgical margins, and outcomes are quite inferior to traditional urothelial carcinoma as such. What is, however, exciting is that these tend to seem to have some amount of response to immunotherapy. Single agent immunotherapy with pembrolizumab has been reported by MSKCC to have a response rate of 32%. So now when we talk of pure squamous carcinoma bladder, remember the initial part which I talked about having a good prognosis and a good response to neoadjuvant chemotherapy was squamous differentiation. Here we are talking of pure squamous carcinoma bladder, most often caused or seen in patients where schistosoma is the etiological agent. There are phase 2 trials reporting that gemcitabine with cisplatin can cause almost an objective response rate of 55%. But again, are they really responsive to NACT, and is it going to provide a survival benefit? We don't know. But one thing we know, a squamous carcinoma bladder, which is non-schistosoma etiology, is chemo-resistant. And that is why in pure squamous carcinoma bladder, most of the sort of consensus statement or authors and institutes report, it is better to go ahead with upfront surgery as such, because you run the risk of disease progression when you're looking at trying to give neoadjuvant chemotherapy. So what is the role of immunotherapy in variant histology? So I looked at 2-3 trials. So we had a single arm pure 01 trial, which looked at, now this is the non-metastatic setting. So first I'll be talking of the non-metastatic muscle invasive setting. Is there any role?
Can we conclude in a couple of slides?
Yes, sir. Last 3 slides. Yeah. So in the non-metastatic setting, pembrolizumab in muscle invasive bladder cancer was looked at in variant histology. What they noticed was that if the variant histology was less than 50%, 67% of them went on to have a response. But if it was more than 50%, only 42% of them went on to have a response. But again, these responses were observed only in squamous differentiation or lymphoepithelioma-like variant. Again, a big study was looked at 395 patients with atezolizumab and pembrolizumab, a retrospective study. And if you can see, in most variants, the objective response rate was between 20 to 30%. Sarcomatoid tended to have a higher percentage at around 38% as such. There was no difference whether it was given in first line or second line, or whether it was upper tract or lower tract. In regular histology, the median was around 11 months. In variant histology, the median was again close to 11 months, no difference. Neuroendocrine small cell in the metastatic setting, aggressive disease, a median OS of only 5 months as such. Nivo plus EP, very exciting, objective response of 37% in 19 patients who had variant histology. You can see the waterfall plot where the different histologies are being seen. And again, too smaller data to show any guidelines. So coming lastly, enfortumab vedotin, we don't have any outcomes in this data, though there were 12% with squamous and 21%. What we know, however, is that it correlates with Nectin-4 expression, but some of the variants such as small cell and carcinosarcomas lack this Nectin-4 expression. So is there hope in variant histology in systemic treatment of variant histology of bladder cancer? Yes. This is the trial which is exciting, which is just started, and there is accrual going on. A proper prospective trial which should hopefully give us some answer and hope, where they're combining dual immunotherapy, nivolumab and ipilimumab with cabozantinib, and the combination of immunotherapy plus TKI, and we know it has worked wonders in renal cancer. We are hoping to see that it is going to work wonders in the bladder cancer. So my take-home points: in a non-metastatic setting, certain histologies require NACT, or they are otherwise associated with poor prognosis. Let us not deny immunotherapy in the metastatic setting just because it's variant histology. We know we see a response rate of 20 to 30%. And going forward, as Dr. Aruna and the other speakers have also spoken about, molecular profiling will help us choose the combination of drugs better. Thank you.
Thank you, Dr. Nitin. That was an excellent talk. I think we are running quite behind schedule, so we will probably take the questions in the Q&A section. May I now quickly invite my expert panelists for a panel discussion regarding variant histology. Can I invite Dr. Raghunath from Bangalore, Dr. Senthil Rajappa from Hyderabad, Dr. Vedang Murthy from Mumbai, and Dr. Santosh from Mumbai again. We'll try to keep it crisp and quick. Most of the talk, most of the aspects of the management is covered, but I would like to try and concise the management of variant histology bladder cancer. So we all now know that, variant histology is not very uncommon and has an aggressive behavior. But the question to Dr. Santosh is, Dr. Santosh, do you think all variant histologies other than urothelial cancers are bad by default?
Yes, most of the times the variant or what we call as now subtype histologies are generally considered to be aggressive. So they are viewed under invasive cancers. If you look at the classification, they are all put under the aggressive cancers. Some like nested may look low grade for the pathologist, but they are actually again high risk. So this is what you have put it here. But if you look at stage by stage, I think squamous and many of the micropapillary would do similarly when you compare for stage.
Yeah, this was a paper published in ESMO in 2020, which actually said that conventional urothelial can be actually high risk in comparison to certain other variant histologies. But typically, the understanding is whenever there is a variant histology, it needs to be looked at very carefully.
So I think very low risk you have put lymphoepithelial. Probably that would not be very agreeable to pathologists. So because they are chemosensitive and they may be amenable to chemotherapy, and that's why.
It is categorized as very low risk. Now, once as a pathologist, you see that there is a variant histology. What other aspects would you like to look at in the slides? And what would your typical report be in addition to what you report on conventional urothelial?
Yes, so many of them, like micropapillary, although difficult to recognize, would have lymphovascular emboli. We generally do not typically write no lymphovascular emboli seen, but in certain like micropapillary and these one, they are definitely more muscle invasive, more LVSI. And like micropapillary, I said, we would look more ardently for a carcinoma in situ. There are multifocal carcinoma in situ is very commonly. So these things would be put into practice.
How often do you deploy IHC in the diagnosis of variant?
Not very. Most of them are very readily recognized under the microscope if we are aware. So the most important thing is this pathologists need to be aware of the presence of this. So 20 to 40% of high grades high grade urothelial would have some sort of divergent or a subtype histology. That's very important. We do sometimes a HER2 and all for micropapillary, but then they don't really translate into treatment in many of these cases.
Okay. And it was also asked by one of the audience, what is the scope of routine molecular classification in variant histology? Would you recommend it at the moment?
I don't think there are any strong recommendations, Dr. Srivatsa, for a low resource country like us. We do sometimes do basal marker and luminal and try to categorize further some of these types and some of these aggressive types. But mind you, they are met with limited utility. So 50-60 would fall into basal luminal if with IHC, but they are not fully translated with molecular classification.
So so I think this slide has been put. So I will probably not go into the details of it. The point here is that though we are talking of the molecular subclassification of variant histology, there's a considerable amount of overlapping even in the molecular subtype, making it actually challenging to ascribe a particular subtype variation. So I think more needs to be done in this regard before we can routinely incorporate the molecular reporting in variant histologies. So coming to the next question, this is to Dr. Raghunath, sir. Sir, is there a possibility of identifying a probable variant histology when you are doing a cystoscopy before TURBT?
It should be possible. Generally, we see urothelial carcinoma as a papillary lesions when we do cystoscopy. Anything other than this, like solid, if sheets of nodularity or thickened mucosa, in such cases, we should always suspect. But it's very difficult to diagnose cystoscopically. Whenever suspicion is there, always try to resect all the abnormally looking tissue.
So any other change other than complete resection that you would probably consider during the TURBT, or would you just like to treat this as a routine bladder tumor?
I would like to treat this like a routine bladder tumor. Histology, pathologists would tell us what it is. Better to resect completely.
So the point here is that we need to do a radical TURBT, especially because we do not know what kind of variation can be there and which patient will go in for a cystectomy and which patient may not probably go in for a cystectomy. So maximal TURBT is probably the way forward. Now you did a TURBT, sir, and then the patient comes back to you with a histopathology report saying T1. high-grade urothelial carcinoma with some variant histology. What are your considerations before you make a decision on management?
So as you rightly said, not all variant histology subtypes are carries poor prognosis. We need to discuss with the pathologist. We request the pathologist to throw some light on this by immunohistochemistry. Based on that, probably we can discuss with the patient whether to go for neoadjuvant therapy or cystectomy, early cystectomy, or some variants can be managed even with BCG. Though the prognosis may not be that good, so we need to understand these things. Accordingly, we should discuss with the patient.
Do you still consider BCG as the best step forward whenever indicated, or would you like to contemplate doing immunotherapy?
I don't have any personal experience with immunotherapy for these things, but I have done a couple of cystectomies and one neobladder we did for plasmacytoid. He is doing extremely well. Of course, he received neoadjuvant therapy, post-neoadjuvant therapy. And a couple of micropapillary variants we have seen. In fact, we were there when we saw one micropapillary. Yes. She just progressed and she died within less than a year.
Yeah. So I think that you have answered. So just to give a perspective, I think BCG does a job, but it has been shown that the progression while on intravesical BCG is considerably more in comparison to the conventional or the standard urothelial carcinomas. Not only will patients tend to recur during BCG therapy, even progression after BCG is considerably higher in comparison to the standard variant, with a 5-year disease-specific survival of very meager 24%. So obvious that we need to try and do more to these patients than the standard of care. So this is an algorithm which has been proposed by Ashish Kamath. This was published in 2015. Where this is not a part of any guideline. This is what they found to be most useful. Whenever they found a conventional urothelial carcinoma or the squamous or glandular differentiation, the nested variant or any other rare variant, they recommended a restaging TUR. If there was no residual disease or they went ahead with the standard of care intravesical BCG. If the tumor was T1 or a recurrent carcinoma in situ, they recommend that we consider early cystectomy. All other variants like the sarcomatoid, plasmacytoid, micropapillary, small cell, or the pure squamous adenocarcinoma should have aggressive treatment with or without neoadjuvant chemotherapy. So, Dr. Senthil sir, the role of neoadjuvant therapy, should we consider treating all of these alike, or would you like to subcategorize like what Dr. Nitin was mentioning? What is your clinical perspective on it?
Thank you for the question, Dr. Srivatsa. I think today we are not lumping these patients anymore. We have to be splitters whether we like it or not. There's no data to split them apart as of now. We don't have clear guidelines on how to manage these patients with neoadjuvant therapy. But just for practical purposes, for the listeners, I would like to divide it into 3 parts. The first category is small cell. I think the issue is very clear as far as small cell is concerned. You use platinum-based chemotherapy, and then you decide on whether you want to do surgery or radiation therapy as your local form of therapy. So I think that's a clear subset. The other relatively clear subset is those with squamous differentiation, glandular differentiation, where there is reasonable consensus that the prognosis is not very different. It is worse compared to the conventional urothelial, but it's not very different. So you manage them like your conventional urothelial carcinomas with neoadjuvant chemo and then follow it up with surgery as you would routinely do. When it comes to the really poorer prognosis subtypes, whether it is plasmacytoid, micropapillary, and all of them, I think these are situations where you might need to take these decisions on a case-by-case basis rather than saying all of these patients should undergo neoadjuvant therapy, because Nitin said, Dr. Ravichandran said, all of them clearly said that there are responses, but those responses don't translate into overall survival benefits. And remember that we are treating patients in order to improve overall survival, not to get responses. So if you have a situation where you're doubtful regarding your resection margins, you think the tumor volume is big and so on and so forth, then for that short-term endpoint in getting a good quality resection, you might want to use chemotherapy there, but not with the intent of an overall survival benefit, because we have clearly not demonstrated that there is a survival benefit. So that's how I would like to categorize and approach this, because tomorrow in the clinic, when you see this You should not be confused and confuse your patient, because that's very, very common. And remember, like Dr. Raghunath said, and all of them have said, putting this up for discussion in a multidisciplinary tumor board where your pathologist is also there is extremely important before you make these decisions.
Yeah. So we know we commonly now have started using cisplatin and gemcitabine as a standard neoadjuvant chemotherapeutic regimen. Would you still contemplate doing the same, or would you fall back on the gold standard MVAC?
Okay, so the pendulum keeps swinging as far as MVAC and gemcitabine platinum is concerned. I think based on the VESPER study, now we slowly moving back to MVAC as our standard neoadjuvant protocol. For patients who are younger and fitter, it is usually MVAC. For patients who are a little older, frailer, it's gemcitabine and cisplatin.
How often, sir, do you see that these patients with variant histology actually progressing on chemotherapy? Any experience?
I don't have so much of experience to tell you how many of my patients have actually progressed. So, but based on whatever Nitin has reviewed in his talk, it doesn't look to be that many of them progress. In fact, surprisingly, quite a few of them respond. So the percentage of progressors usually over the board with neoadjuvant chemo is less than 10%.
So is there any specific case where you will not consider neoadjuvant chemotherapy?
All these bad prognostic histologies where clearly there is no role for neoadjuvant chemotherapy, that ones that we spoke about, straight away cystectomy if you can operate, everything else should be considered for neoadjuvant chemo.
Yeah, thank you very much, sir. So this is to summarize what we have just explained for us in great detail. So neoadjuvant chemotherapy still forms a very integral part of treatment of even variant histology cancers, and certain cancers with very high risk features with hydronephrosis or impending risk of disease progression can be contemplated for an early upfront cystectomy. The last question to you, sir: role of immunotherapy, which is the ideal case? What do you prefer to do, and do you want to consider it as a part of neoadjuvant therapy?
I think one very important point that we all should understand, and it is applicable over all anatomic subsites, is that we should not take prognostic indicators as predictive indicators. One of the things that we always do is that if you think somebody is going to have a poor prognosis, we immediately say, do chemotherapy. I think that's not the appropriate approach, because we may have to handle these patients by a different set of drugs, a different strategy altogether. It might be immunotherapy, it might be targeted therapy, and so on and so forth. So we should not always equate prognostic indicators to responsiveness to chemotherapy and outcome impact because of chemotherapy. So this is very important to keep in mind. Now, the reason why I said this, I saw your algorithm, and every article will give you a slightly different algorithm. There's nothing very standard about this. So which case, again, 3 subsets that I told you, one certainly, the other relatively certain, the other is uncertain. The uncertain is those really bad prognostic groups. Preferred drugs for younger patients, MVAC. For the older and frailer, it's gemcitabine and cisplatin. If they're not cisplatin eligible, no neoadjuvant chemotherapy at all. No immunotherapy as of now. That's not standard, at least in the neoadjuvant approach.
Great, sir. Thank you very much. The last few set of questions, these are for Dr. Vedang Murthy. Sir, do you consider variant histology bladder cancers to be as radiosensitive as the conventional urothelial cancers?
In general, no. Except for small cell, which are more radiosensitive, as they are more chemosensitive. They may not be radio or chemo curable, but they are certainly sensitive. So other than that, squamous and adenos are just like any other site in the body.
So if there was a patient with a very low volume variant histology, muscle invasive bladder cancer, would you still recommend, a young patient who wants to preserve his or her bladder, would you still contemplate offering trimodality therapy in this kind of?
Yes, I think based on all what the speakers have just said, stage for stage, we would consider them as, we would treat them like urothelial cancers. And if it fits the criteria for bladder preservation and the patient wants it, and the urologist wants it, then of course we should offer it. if there is only a little bit of variant histology, because I don't think that changes. It may be prognostic, but I don't think this is predictive to what exactly what Senthil was saying. I don't think having a small amount of variant histology, not the very bad ones, changes what the outcome based on treatment. So I would.
Thank you, sir. So I think you have partly answered this question already. Which subtypes of bladder cancer are probably more amenable to radiotherapy?
So I'd like to point out two things that were not mentioned in the talks. One is for small cell. So it was very elegantly showed that chemo is clearly important. There's no question about it, but chemo alone is not enough. There has to be a local treatment. And even the guidelines and the speakers also said that it could be radiotherapy or surgery. My take here would be clearly outcomes are bad. The outcomes for small cell, the median survival is 2 to 3 years only as compared to urothelial cancer. It's bad. So I would tend not to remove somebody's bladder when the failures are likely to be distant and the tumor is sensitive to radiation. You may get away with a smaller dose, 55-60 gray instead of 60 to 64 gray. So that is something that I would definitely keep in mind while treating small cell cancers. The other thing that I may just wanted to point out is, and we discuss this often in our JC, just like lung cancers, we kind of sandwich the radiation or surgery, or basically local treatment, in the cis-eto regimen, that is 3 weekly, I think. So the problem is, what do you do with the concomitant bit? Giving cisplatin etoposide concomitantly with bladder radiation becomes very difficult for the bowel and other things. So we remove the etoposide and just do the cisplatin at that time. So that is a little tweak that we do during treatment for small cells. The other thing I would like to point out is squamous cell carcinoma. One must not forget that there is a clear and definite level 1 evidence for adjuvant radiotherapy in squamous cell carcinoma that was not mentioned by the speaker. So I think that is important. You do see pure squamous in your practices, and after treatment, I think even if it is T2 high grade N1, surely the local recurrences are in the range of close to 50%. So adjuvant radiotherapy is important. One practical issue there is many of the radoncs may not be comfortable doing adjuvant radiotherapy for bladder. There's so much bowel there. There's so much of, there could be addition. There is always a risk of toxicity, but we have treated several patients in a trial and outside trial. There's a lot of literature that it can be done safely. So I think it should be strongly recommended.
Great, sir. Thank you. And again, probably when we are operating on a squamous cell carcinoma, this thing has to be kept in mind.
Yes. It's often easy to overlook that fact, but it is important because local recurrences can become a problem.
Yes. So these are probably one category of bladder cancers where neobladder may not be a good option.
Correct.
So I think you have already, this is the report which showed that, small cell bladder cancers do very well with concomitant chemotherapy as well as radiotherapy, and radiation has been marginally shown to be beneficial over surgery. To summarize, I think the knowledge on variant histology is evolving and the incidence is higher than thought. So we need to be very careful when we interpret the reports, because it can alter the way we manage these patients. And certain histologies are aggressive and probably needs a differential approach. There are, as of now, no standard guidelines for overall management of variant histology. And wherever possible, I think systemic therapy should be an integral part of management of these histological subtypes. And like Dr. Senthil and Dr. Vedang mentioned, I think a multidisciplinary tumor board discussion is probably the best step at present for decision making in patients. I thank all my panelists, all the senior faculty and the Council of SOGO for this wonderful opportunity. I think personally, I learned a lot about variant histology today, and thank you very much for the time. Over to you, Raghavan, sir.
Raghavan is not available. Raghavan has entrusted me to wind up the session. Before
Yes.
that, Dr. Jagadish Kulkarni is want to make some comment. Sir,
Yes.
please.
Yes.
Well, this is a question to Vedang. Remember this, we used to have something called as, 400 into 5 preoperative radiotherapy, or 400 into 4, and then Monday to Friday and followed by cystectomy. Do you think we have to revisit with the nuances in the radiotherapy? We should revisit this, especially in a variant histology, and maybe we can add something. So it will be truly contributory.
Sir, I remember it only from textbooks. I am not that old. So, so I don't know. I have never used it. I think it was done in the early 90s and
Yes.
late 80s. And the randomized trials really did not show a benefit of that over adjuvant treatment, and a lot of chemotherapy has come in. So I don't know why radiotherapy would benefit for variant on its own. I don't know why that would be the case.
Especially you said about small cell carcinoma, whatever you're talking about.
Small cell is different. Small cell is different. But otherwise, I don't know why it would make a difference. I just had one point, if I may just add, Srivatsa, for squamous. There may be instances, and we've done this for a few patients with great results. There may be instances where patient may just not want surgery in a squamous, or cannot have surgery for various reasons, and that does happen in the real world. So why treatment fails in squamous radiation is because we are not able to give an adequate dose. 60 gray is not enough for any squamous cell carcinoma, that is gross disease, but we can treat to a higher dose with the radiation that's available today to a small area of the bladder. You see, squamous is not multifocal. We don't need to treat the whole bladder. We can just treat a small area, and that can be a useful thing for some patients, at least in practice. That I just wanted to point that out.
I think Ganesh sir has a couple of questions quickly. Sir, Ginil sir, if time permits, can I?
Yeah, please.
Yeah. Bakshi sir has asked, would you do a pathology review if you see a patient coming with variant histopathology? I think we should always do, if the procedure, TURBT has been done outside and has been reported outside, I think pathology review is probably mandatory. I think a lot of information can be forthcoming. And I think, like we discussed, it should be a part of a multidisciplinary tumor board discussion as well, subsequent to the pathology review. The second point that sir has asked is, we discuss surgery, immunotherapy, and chemotherapy. Many patients are treated by radiation oncologists also. So what are the results in smaller series? I think Dr. Vedant can answer this.
Ganesh, we looked at this as part of one of my students' thesis last time. And in fact, Santosh went back and reviewed all the variant histologies of the 70-ish that we had. About 35-40 were variant histologies. And I don't think we found a difference in, so these were not pure, but variant histology. We did not find a difference in outcomes, all treated with radiotherapy. It's not published, but we are working on it.
Really great, because this kind of data should start trickling.
Yes. So, yeah, we are probably thinking of, comparing it to the variant histology of cystectomies, also the one that you have done over so many years.
A very small 10 seconds, Srivatsa.
Yes, sir. Yes, sir.
So a patient NMIBC, which was hugely PT1 high grade, and there was a 4 millimeter lesion which was separately repapillary. It had been through a review through TMH also after incision. So now the question is what to do. Patient says 4 millimeter micropapillary. Why should I lose my bladder? So all kinds of data, like Vedant said, should be probably somewhere collated and given out. That's it. Thanks.
Yeah. Thank you, sir. Ginil sir.
Thank you, Srivatsa and team. Actually, variant histology is a rare thing, and is very, not only to treat, to discuss also, it is very difficult. So you have done an excellent job. I congratulate the entire team. All the speakers done very well. I'm not going through all the minute points which was discussed because all the discussion was very clear. So there's no need to repeat all the things since we are late. I'll just wind up the meeting with a note that these discussions will be available in the server site for its members, and we can review it at any time you want to. Thank you all for joining us in this meeting, all the panelists, all the delegates, and all the speakers. Thank you very much.
Thank you, sir.
Thank you so
And
much.
as a parting message, can I request audience who are not yet part of SOGO to be a part of SOGO, whoever is interested in management of genitourinary cancers, regardless of the specialty that they work in, can be a part of SOGO and can, share their experiences and also enrich their knowledge. So I think it will be a great thing to get into SOGO and be a part of.
Thank you, Sri.
Thank you very much, sir.
Sure.
Thank you.
Thank you.
Good night.
Thank you. Thank you.
Thank
Good
you.
night.
Sir.
Night.
Good night.
Thank you, Shivat. Thanks a lot.
Bye-bye.
Bye-bye.